So after months or years, see significant immune breakdown of Th1 and overstimulation of Th2. So you can usually, if people get Lyme, you can get treatment early. Yes, you can get rid of it, but over time, it just starts breaking down. And once you get to that tipping point, you can no longer effectively treat it easily. You may never get rid of it. Again, it's kind of like all these infections that you basically suppress, but they're not gone. You may never become symptomatic or continue to be misdiagnosed with multiple other conditions, bipolar, depression, autoimmune disease, lupus, name it, and we're finding that you'll see those, and you fix the infection. And it's so funny, and people say, I don't believe in, okay, you believe this person has 42 other diagnoses. Is that, but they don't have Lyme, okay. And longer the duration, generally the worse the immune dysfunction, the worse the symptoms and the more treatment resistant. Co-infections make it worse. My sense is Lyme is not that hard to treat. I think it's the co-infections like Babesia is the scourge. But antibiotics as a sole therapy currently rarely result in long-term improvement because it's like an AIDS patient. I mean, you can't give enough antivirals or antibiotics to get rid of the infection. Your body has to be able to clean it up. So you need a multi-system treatment. Includes fixing the immune dysfunction, which we'll talk about, the coagulation defect, which may be a little new information for everyone, so I wanted to touch on that. Hormonal deficiencies we'll talk about. There's gastrointestinal, pain, sleep, detoxification, molds, mitochondrial dysfunction. So usually to go through all these, it's about a 7-day PowerPoint. But nutritional deficiencies. So immune evasion. So fast-growing infections are usually the most susceptible by antibiotics. So they really only get the infection when it's growing and replicating very quickly. Borrelia is very slow replication rates. Then it goes into a stationary phase, and then it actually starts putting off persister cells, which are basically in suspended animation. They aren't metabolically active. So they become extremely resistant to antibiotics because antibiotics generally only work, they block replication. So you can give 20 antibiotics at 20 times the dose. They're just going to hang out. As soon as you stop, boom, comes back. So you look at, let's say, a sinus infection. Your sinus infection starts growing, you take an antibiotic. Now it will mutate, and now the antibiotic gets resistant just as a random mutation. The ones that are resistant basically live, so it's a new strain. Lyme doesn't work that way. It basically just sends off these cells that you can't touch it, then as soon as you take away the antibiotics, it comes back as the same strain. So again, Lyme disease, slow growing with periods of little or no growth. The slower the growth, the longer it takes to kill. So if you look at the doubling rate of, let's say, again, sinus infection or whatever infection, staph or strep is about 20 minutes. So Borrelia takes 12 to 24 hours, and a lot of times even longer. Once you hit it with antibiotics, it's going to even slow it down more. So it's about 35 to 75 times longer, okay? And so what does that mean? So usually we give an antibiotic 10 to 14 days to make sure we kill the infection, right? So in order to have that same, certainty or ability to make sure we clear that infection, we need to take an antibiotic basically 24 hours a day for 1.5 to 3 years for the same curative potential. So, you wonder why it takes so long and just say, okay, take these antibiotics for 3 years and call me in the morning, So that's one big challenge with it. So immune dysregulation induced by Borrelia not only impact the ability to diagnose, because most of these tests are indirect measures, right? We're looking at antibodies against the infection. Now, if the immune system's suppressed, you don't make any antibodies to it. So all these, so many false negatives. And especially, for instance, and with Western blot, you'll see, especially with IGeneX, a lot of IgM antibodies positive. And people say, oh, it's a false positive because it's you only see that in an early infection. If they've had symptoms for longer than 6 months, it's a false positive. No, actually with this, when you have low Th1, you actually don't make enough interferon gamma, which allows the cells to convert IgM, which is a very weak antibody, doesn't involve complement, just kind of sticks onto the bacteria, kind of like on your leg and dragging it. It's a hassle, but it's not killing you. Where the IgG explodes it, but so it keeps the body from transferring over, so you don't get IgG antibodies. And if you see low IgG subclasses, the neurologist will go, okay, it's a genetic, okay, if we kill the infection, it will actually go back to normal. But gamma globulin, again, works, but usually works for the immune modulation, not just for raising the gamma globulin levels. But, so you really need an intact immune system to get the diagnosis. So identification of immune dysfunction can help aid in the diagnosis, but also in therapy. And really need to address it for long-term success. So again, in later stages, the Borrelia infection suppresses the production of interferon gamma, including which also activates natural killer cells. So you want to check natural killer cells. About 70% of chronic fatigue syndrome patients have low natural killer cell function, and about 30% have low natural killer cell number. So the test is natural killer cell number through LabCorp, or even better is with Quest. There's other labs as well that checks natural killer cell function, will be much more sensitive. And we talked about the IgM to IgG response. And in contrast, again, the Th2 T cells response in an inefficient IL, it's an interleukin-4 dominated response where you get the IgM antibodies. So again, Th1 intracellular, Th2 extracellular, inflammation, all those problems. So what the Lyme will do is basically it'll go extracellular, then it will suppress the Th1, then go intracellular. So now you can't kill it. So it's kind of this way of basically that's when it converts to long term. As soon as it suppresses your Th1, it goes intracellular. Now your body can't kill it. And it's a sign of, again, late stage conversion. So we have a microscope, dark field, light field as well, with immunofluorescing antibodies in our office. We lost our tech, but the tests were mainly for Borrelia and Babesia, where we could do the immunofluorescing antibodies. So very specific, no false positives. And what we're finding is about 25 to 30% of the population has Borrelia and or Babesia. Now, it gave me certainly a skewed population. People are coming in because they're sick. So, but finding it much more common than is currently believed. A number of studies have shown that. They had migrant farm workers coming in, majority asymptomatic, about 30% were positive for Babesia and or Bartonella. It's in the blood supply. So 70-80% of those are shown to be asymptomatic. Oftentimes, if you take a detailed history, though, then they'll start saying, oh, yeah, I am fatigued, I'm achy, oh, yeah, I get night sweats. And so they're not, again, it's that, subclinical hypothyroidism means, no symptoms. Well, if you don't ask, you don't hear any symptoms. But what you'll find in those patients is, again, you'll start seeing that Th1 suppression, low natural killer cell function, high Th2, high C4a, the coagulation markers we'll talk about, and we'll talk about other markers on how to identify those patients. So the majority of asymptomatic infected patients will have low immune function, again, low natural killer cell number and function, but they don't yet have the inflammatory markers, C4a, eosinophil cation protein, and Babesia is very difficult to find. Even IGeneX test does the co-infection testing. It's expensive and it's not that accurate. Now, so ECP, you can get it through Quest, and it goes up. You'll read it can go up with allergies and some other things, but you have to have such bad allergies. Now, a lot of times it's high normal, but if you treat with antiparasitics, whether they be herbal, and there's a lot of great antiparasitic and antibacterial herbal products out here, and then test it again, all of a sudden it goes sky high. So you've pretty much got a very good diagnosis for a very cost-effective diagnosis. Human transforming growth factor beta is also a Th2 that you'll see high, good to get on patients, and I'll review these at the end. And so C4a is another marker, and some studies by Shoemaker shows it's a good marker. It's not totally specific, but you'll find it really correlates with the disease severity. Now, Quest is having a difficult time doing it. They have to get dry ice, and so they're now not offering it. So, but the human transferring growth factor beta is a good alternative to that. So, and we'll go through what's a basic panel to get, and you'll be able to identify these patients much more comfortably, quickly, and be able to help your patients faster, and also show objective improvement instead of just in patients like, I don't feel better, but if you show, hey, look at your labs are better, you're going to keep them motivated, which is a big part of helping these patients. Leptin, again, another immune modulating thing. They'll get leptin resistance, so any leptin above 12. Immune activation of coagulation, and I'll go more into depth on this, D-dimer, thrombin antithrombin, soluble fibrin monomer, prothrombin fragment 1 and 2, plasmid angiotensin activator 1. So I know it's like too many things, but we'll go ahead and go through it. The CD57, so that's a natural killer cell number. Oh. Yeah. Appears that when the inflammatory markers increase, that's when they become symptomatic. Again, the data that we found with so many people having it fits, again, I mentioned the migrant farm worker study, found 20 to 30% tested positive by PCR and microscopy. Most of the people were asymptomatic in a very brief questionnaire. Also, if you look at the Stanford study where they had patients, this was a chronic fatigue syndrome study, but they had their blood years before they had symptoms. And what they found is they had immune suppression on average 3 years before they had symptoms. Only when they developed the inflammation did they get symptoms. So really, you want to treat the immune dysfunction along with the infectious component. So we want to look at immune modulating therapies that will increase that Th1 and decrease that Th2. So boosting natural killer cell function, lowering inflammatory cytokines. So some things we'll talk about today, low-dose naltrexone. Are people how familiar with that? Or raise your hand if you're using it. Yeah, fairly enough. Good, good. Peptides, which is a new therapy that I'm just excited about, and just some amazing things. You can't believe the studies on it. Like, why have we heard about this before? And the biggest negative is they're not the cheapest things around, but hopefully that will change. I'm going to talk a little about heparin. Kind of freaks people out, but it's safer than giving aspirin. And there's also other, basically, homeopathic or nutritional supplements that I can use for that. Ozone I won't talk about, but we love it. High dose, direct ozone, injecting ozone directly into the veins. You can do that, but the new thing is, so MAH and ozone people, anyone doing ozone? A few. And that's another great therapy. It directly kills a lot of these infections, but really a big thing is it modulates the immune system. And if you do, I don't know, probably some people are doing prolozone, injecting into joints. I had osteoarthritis, basically it was from Lyme, with labral tears, and did stem cells, PRP, just ozone. I think ozone probably just as good, if not better, than anything else, which is much more expensive. Ozone is really easy to do. And now we're adding peptides to it, and we're getting very good effects with not so much cost and hassle. Leukine Neupogen, which is basically used to boost the immune system. We'll do it in much lower doses. I'll just mention a little bit about that. IV silver, chelation, low-dose allergen, low-dose immunotherapy. Again, I won't talk a lot about it, but those are some good things to check out. Ty Vincent has been doing a lot of great work on low-dose immunotherapy. IVIG, and this is a list of all these other things. Again, we can't talk about all of them, but just to be aware, when we pretty much do all these here, bee venom's actually helped a lot of patients. We don't do acupuncture, but studies show it actually does increase Th1, lowers Th2. So here's just an interesting study out of Immunology Today, looked at HIV patients and their progression to AIDS, and it basically directly correlates with the reduction in Th1 and the increase in Th2. So that's how they progress. So stop that progression, you stop the progression to AIDS.